today, inshallah, we will talk about chest tube. What is chest tube? It will be, inshallah, 15 minutes as a theoretical part, physiology and anatomy of the chest, just to know how we breathe, the mechanism of breathing, just to know and understand the mechanism of how chest tube is working. Okay? After this 15 minutes, inshallah, will be practical. How to prepare chest tube, what's the complication of chest tube will happen with you, what's the nurse duty for chest tube. Okay? No, I can't. I will make it loud. This one is working. Yeah. So, what's the chest tube? I want you to answer, okay? What's the chest tube? Inserted in the chest. For what?
For pneumothorax.
Yeah, for drainage. For drainage. So, chest tube is just another drain, right? To drain either air or pulse or blood. It's a drain. At the end, it is a drain. Some anatomy. You know the lung, the chest cavity. There is membranous part that's envelop the lung. Do you know the name of it? Nobody knows the name of the membranous part that envelop the lung? A pleura. It's a visceral pleura, right? There is two types of pleura. Visceral pleura and parietal pleura. That's right. The visceral pleura is envelop the lung itself. Parietal pleura envelop what? The chest wall, chest cavity. Okay, so the chest cavity is enveloped by parietal pleura and lung is enveloped by visceral pleura. The parietal pleura is innervated, so all the pain comes from parietal pleura, not the visceral. Suppose there is a wound here, and I put my finger, touch the lung of the patient. You will feel anything? No, nothing. Okay? But if I touch the chest wall from inside, he will feel the pain. Okay? So this visceral pleura and parietal pleura, is it separated or intact? Separated by a space? Is there any space between them? Huh? No, there is no space. This is a potential space. These two membranous parts is always intact to each other. There is no space between the visceral and the parietal pleura. Okay? Why there is no space? Why? Think. So when I inspire, okay, and expire. When I inspire, what I'm doing? I just contract my diaphragm, okay? I contract my diaphragm and expand my chest wall. So this creates what? Space. Negative pressure. Negative pressure inside my chest. Negative pressure inside my chest, my diaphragm is going down, my chest wall is expanded, so I create more negative pressure, so the air will come into my trachea, right? So this is inhalation or inspiration. What's the expiration? My diaphragm is going up, pushing the lung, pushing the air. It creates more pressure on the lung to force the air to come out from my trachea. Okay? This is the physiology. So, the pressure inside the chest or the pleural cavity is negative or positive? Negative, right? So it's more negative on inspiration or expiration? More negative. Inspiration. At expiration, is it positive? At expiration, is it positive? No. It's not. It's always negative. Okay? At the end of expiration, it's -5. At the end of inspiration, it's -15. So it's always negative. That's why the parietal and visceral pleura is always intact, because it's always negative pressure between them in the pleural cavity, so they are always intact to each other. Okay? So let's review something here. The lungs are wrapped by a double-sided envelope of tissue called the pleura. Okay? The innermost layer is called visceral, and the outermost layer is called parietal. How we breathe? On inspiration, the lungs move, no, not the lungs, the diaphragm moves downward. The visceral and parietal pleura are separated by a thin film of what? Pleural fluid, right? Yeah, I know they are intact, but suppose there is no fluid. What will happen? There is more friction, right? And we will feel pain. We will feel our lung moving, but we don't feel well with that. Why? There is a thin film of pleural fluid that lubricates the visceral pleura or parietal pleura during respiration. On inspiration, the cyst will expand and the diaphragm moves downward or upward? Downward. During inspiration, the pressure within thoracic cavity is less or more the atmospheric pressure. Less. It's negative. Okay? It's negative. Our atmospheric pressure, by the way, it's positive pressure. Okay? So air can rush into the lung. During expiration, the intrathoracic pressure is less or more, allowing air to exit the lung. Less or more what? Less or more from inspiration. Okay? Not from the atmospheric. It's always less from the atmospheric. So it's more than inspiration, so it's push the air. If air or blood. So let's talk a little bit. This negative pressure. Imagine that I stabbed myself now. Okay? It's a closed space, right? My thoracic cavity and your thoracic cavity is a closed space. If I stab myself, I open this, what will happen? Air will go inside because it's negative pressure here, always. So, this negative pressure is distributed now, right? And the lung, what will happen with the lung? It will collapse. So, some definition here. If air collected into thoracic cavity or pleural cavity, what's the name of it? Pneumothorax. If blood, hemothorax. If pus, empyema, yeah, right? Or biothorax. Or if air and blood, hemopneumothorax. If pus and blood, pneumothorax. Okay? So just medical terms. If air or blood is introduced into the pleural space, the normal pressure are distributed and the lung will collapse. To drain this air or fluid of the pleural space, a chest tube is needed. So, the main function of chest tube is what? In better term,
to regain the pressure of the lungs again.
That's to regain or to maintain the negative pressure of the thoracic cavity. Okay? This is the main function of the chest tube. Here we talk about it. Pneumothorax, air. Hemothorax, blood. Hemopneumothorax is air and blood. So, what's the lightest? The air or the blood or the fluid?
Light. Air.
The air, right? And the air will go up, always up. So if you put your patient, you are in ICU, putting your patient at 45 degrees or spine, right? So the air will go where? Up where? Apex or anterior or posterior? The air. If the patient's supine, the air will be anterior, right? Because I'm supine, this is the most upper point of my body. If I'm standing, this is the most upper point at the apex. So, when I put chest tube, you may not pay attention for this, but if I put chest tube for a pneumothorax, I put it where? Anterior. Anterior till the apex. But if I'm putting chest tube to drain a blood, where I'm putting it? Basally and posterior to the patient, because the patient in ICU always supine. So I put it posteriorly and basally. Okay? So pneumothorax chest tube will be placed at second intercostal space, since air is lightest. It's not second, by the way. It's fifth always. The insertion is fifth, but I reach second by my tube. Okay? And if blood or pus, I put it basally till 7 or 8. This is what we are talking about. Did you see here? Or the light is? Okay. This is the trachea. This is the line. What is this layer? What is the name of this layer? Visceral pleura, right? What is the name of this layer? Parietal pleura. So those layers have to be intact all the time. Okay? If there is a space between them, there is no negative pressure. So this is just tube here for the air, and this is tube for the basal one. For what? Fluid, rather than pneumothorax or pus. Okay, types of drainage system. Don't pay attention for this. We have only one system here. It's a pleura valve. Okay. I will talk a little bit about the classic one button, just to understand the mechanism of chest tube, and you can apply it for a pleura valve. This is one button system, a 3-button system. I want you to remove this button from your imagination, this one, and this one. Okay? Remove it. Consider it's not there, and consider this is the underwater seal. You know the chest drain is called underwater seal. Why? Why we call it underwater seal? Because the tube is under 2 centimeters of water. Okay, which tube? I will tell you that. So delete this and delete this. Consider this tube, this one. Did you see? It's obvious, huh? Consider this tube is going from the patient itself. Okay? This from the patient, and this one is open to the air. So, if I'm draining air, the patient will cough. It will push the air outside the chest, right? Till the tube here. What will happen to the air? It will come through this. I will see bubbles, right? Underwater. Right or not? Yes. Okay. So, if the patient will inspire again, he will create more negative pressure, right? The air will come into, we're trying to come into, from where? From here. This one is open to the air, right? Okay. Suppose the air will come from here, it will try to go inside the patient from here, right? To the chest tube. What is on its way? Water. It cannot come. The air, it cannot insert again because there is water. Okay, resist him. Resist the air. So this is the underwater seal. It's like one-way valve. Allow to air and pus or blood to come out and prevent the air to go inside. This is the underwater seal. Allows the air will come easily from here, bubbles, and when the air tries to come inside the patient, to resist by water. Here is the principles. The idea is to create a one-way mechanism, one-way valve mechanism that will let air out of the pleural space and prevent outside air from coming in. It's like one-way valve. This is accomplished by the use of underwater seal. The distal end of drainage tube is submerged in 2 centimeters of water. Okay? Did you understand the mechanism of underwater seal? It's easy, right? Because this is the most important mechanism I want you to understand. How would the underwater seal help in restoring negative intrathoracic pressure? We answered this one. How? To allow air to come out and prevent air to come inside again. What is it? talk as a practical after a while, but now, if we clamp this tube, what will happen?
Nothing will happen.
Nothing will happen. Okay. What will happen?
We are pushing the air from the tube inside.
No, this if we deattach it.
Also, we declamp it.
No, if we clamp it only.
The air will go out.
Yeah, the air will not come out, or the fluid will not come out. So, you are guys in ICU, all your pneumothorax is like this. There is two types of pneumothorax. Okay? There is open one, chest wall, chest injury, stab wound, any opening in the chest. And there is a closed one. What is the closed one? The air will come from where? Suddenly a patient with you on ventilator and your doctor says it's a pneumothorax. Why? Nobody stabbed him. Barotrauma. It's from the lung. Okay? So when the lung is injured, barotrauma, that means a pressure trauma. A pressure trauma. The lung is spongy. When I push massive air or a pressure more than usual for the lung, especially diseased lung, it will rupture or injure from inside. So the air will come from the lung to the pleural space, okay, collecting into the pleural space. But the chest wall is closed. There is no wall. Okay. So when I inspire or when I inspire, during inspiration, what will happen? The air will come out from the lung to the thoracic cavity, and the thoracic cavity will be positive pressure, not a negative pressure, and the lung will collapse. Okay? So, if you clamp this tube while the lung is injured, what will happen? The air will continue to come out to the pleural cavity, creating more positive pressure, and what will happen? What will happen? Loudly.
Complete collapse of lungs.
Complete collapse of lung, and then more positive pressure. What will happen? No. This positive pressure will compress at the great vessel and the heart, right? This positive pressure will start to collapse the lung. Then, after a while, it will start to push the great vessels and the heart. What will happen if the air pushes the heart? What will happen? You know the cardiac output and input? Okay? So the cardiac input will decrease or increase? Decrease, because I am pushing it. Okay? So the cardiac input will decrease. What will happen to the patient? Hypertension plus hypoxia. So you saw the patient, you all saw the scenario. Hypertensive, hypoxic, we put chest tube, all of a sudden the blood pressure will normal again, or hypertension because I throw, and saturation will be normal. Right? This one. What we call this case? Tension pneumothorax. So this is tension pneumothorax. When the patient starts to collapse or hypertension, this is tension pneumothorax. Because tension pneumothorax, normally there is no tension pneumothorax in the street. You will not find tension pneumothorax in the street. Why? Because there is no ventilator. The ventilator is just pushing air into the lung by force. Okay, and the air is collecting in the pleural space, creating more positive pressure. And ventilator, you just increase speed, you just increase the titles, you just give more air to the lung, collecting more air into chest cavity. Okay? This is tension pneumothorax. It's on an ICU condition only. So when we put chest tube, what we are doing? Collecting this air again. Okay, lung expanded, and the negative pressure is maintained. You see, this is tension pneumothorax here. The air will collect, compressing on the lung will collapse, and after a while it will start to press on the great vessels and the heart. So what's the tension pneumothorax clinically, not radiologically? We talk about it.
I have one question.
at this. Imagine that the lung is injured here. Okay? We give air. The air will come out of the lung, right? Where is that? The air will come out of the right from here. Suppose. Okay. When the ventilator take same tidal volume, you say, it will not take it. Why? The air will not come in inside the chest again. It's one way only. One way valve. Why? Because the first, if you know, there is trachea, main stem bronchus, and then bronchioles, and then alveoli, right? Did you imagine that alveoli can collect the air from outside? No way. No way. Because I'm just giving it air, air will escape from the lung, no way to come inside again, inside the lung, inside the alveoli again. Okay?
But the alveoli is only for the perfusion, not for the air will go in the alveoli, it will come out.
The air, it's ruptured alveoli. Ruptured alveoli.
So if it is ruptured, so there will be no
I will make it easy for you. Imagine there is gloves. Get a finger of gloves, right? And cut the tip of this finger and blow it. Okay, it will blow, right? And try to suck. Is it suck? No way to suck. It's membranous part. Okay? And this is so the trachea, intention pneumothorax, you will find the trachea is deviated. Tell to the healthy or to affected side?
لا healthy side.
Yeah, to the healthy side. Because the affected side is breath on the healthy one. Decreased or absent breath sounds on the affected side. Blood pressure drops. Tachycardia, dyspnea, and hypoxemia, and decreased cardiac output. This is a pleurovac we have in the hospital. But our pleurovac is covered, so I personally did not understand what's going inside this. So this one is exposed a little bit. All the pleurovac have 3 chambers. Okay? All the pleurovacs have 3 chambers. This chamber is collecting the chambers that you are mounting every day. And this chamber what? Underwater seal, you can see the tube and the water is here, and this tube is for suction or negative. Criterion, that's what we have. Open pneumothorax, we talk about it. Closed pneumothorax, we talked about it. Nursing responsibilities, cares of the patient with chest tube. What's your responsibility of chest tube? What's your responsibility? Don't look at the monitor, look at me. Alas, we know now the mechanism of underwater seal, right? So, this tube will work by gravity, okay? Imagine that I'm putting a chest tube, the underwater seal maintain my negative pressure. Imagine that I raise my underwater seal above my chest. What will happen? The fluid or the air will come again inside my chest, right? Why? By gravity. Okay? By the gravity. So, the most important thing is to keep the underwater seal or the chest drainage system below the patient. Not below the patient, below the chest. Okay? Below the chest. Meter or meter and a half. Always below the chest. So if I want to transfer a patient to the radiology unit or to OR, what to do with the chest seal?
Clamp.
Clamp. Okay? I have to clamp it before going out of the patient. Second most important thing. What? Hello? Kings. 20 minutes? This tube is tinkered. It's not functioning anymore, right? So please, you called me 10 times or more than 10 times over last month. Pneumothorax. This tube is not working. The patient is collapsing. and I came just found the tube is kinked below the patient. Okay? So before anything, you have to be sure always the tube is not kinked. Okay? What else? What else? Nursing responsibility.
We have to make sure if there is a drainage or no drainage. It's
Bound the
bubbling or
drainage.
not bubbling.
Okay. What else?
Oscillations or not.
You have to check if the system intact or not. Suppose it's disconnected from the connection. Okay? The air will come inside the patient again. Right? And plus, what else?
Checking the side of the insertion. It's intact or not intact. Maybe it's inflamed and we cannot see it because of the dressing and these things.
You are right. The tricky thing is that when we put chest tube, we put it obliquely like this. Okay? And we put a dressing. Some chest tube inserted like this. Okay? And when you guys put the dressing, what will happen? It kinked. It kinked inside the dressing. So try to put some gauze. If you saw the tube like this, not like this, just try to put a gauze below the tube.
Excuse me, I have one question.
Yeah, go ahead.
Is having a chest tube, we should give position to that side or not? Because if we give position, the tube will keep.
As a positioning of the patient, right? You're asking for positioning of the patient? Yeah. You can position the patient 45 degrees, but just sure that the patient is not slipped on his chest tube.
Because when we turn the position, it will compress the tube.
No, halas. You cannot repositioning him on his chest tube. You can't.
So we should avoid the
The
position.
most important thing in chest tube patient is the chest tube. Okay?
No positioning.
So Dr. Attia will bring you the paper and you will write down there?
Not
Now we will fill this. I don't know how many, about 300 or 200, just to
bus. 50.
reach the yellow mark. Okay? We don't have enough time. Huh? No, it's not sterile technique at all. Okay?
Clean.
It's a clean only. Yes. Don't forget to cover the seal again. One. There is a problem here. If we found this dual collection, what are we supposed to do? Close the other one, right? Why? Because this dual collection. Okay, see this single collection? It's sealed, closed. The air will come from here into the underwater seal and come out from the ventilators. You will not see it. Okay? But this one, if this is connected to the patient, this is to the air, what will happen? This is not secured, right? The air will come from here into the patient again. So the most important thing is to clamp this. How to clamp this? The best secured way I found is to tighten it like this. And just be sure that you tie it well. I can tie it like this. It's considered tight. I can tie it like this. It's considered tight, right? No, tie it well. This tightness. Okay? It's air sealed. And then you can cut and put some sealant on it like I'm doing. Okay? To be sure. Then chest tube of the patient. My system is ready. Okay, all the chambers is ready. Chest tube is clamped. Deconnect the old one and connect the new one. Declamp, don't forget to declamp it again, because a lot of us forget to declamp it again. And test. What to test? Before negative suction. What to test? No. Is it working or not? Okay? Is it working or not? So suppose I'm a patient, suppose this chest tube is connected to me, and I'm taking my breath. Okay? It's clean, I'm sure. Because she don't have right. See? This is a normal breathing.
طلع في التلفزيون
This is a normal breathing, okay? Inspiration will create a more negative pressure. Will what? It's like the water, right? The water prevents me. See, the water prevents me to. I cannot suck air. I can't. But I can blow it easily. This is one-way valve. Okay? So, what's the name of this? Oscillation or tidalization or fluctuation or anything.
If you take this tube down and you will take the chest tube 1 meter up, is there any chance from the fluid to come down?
Yeah, it will come down.
So how come it's one way?
Yeah, because the water is heavy now. Okay, if I put it this 1 meter, okay, I can. If I pull, sorry, the water will come out to me. You don't store gas from a car while you are young.
You don't know it.
So, you put a gasoline. You don't store a gasoline from a car before.
Yes.
The child that will have no any valve, but this one has.
No valve. There is no valve here also. This is not a valve. The valve is the water only. Okay? The water is prevent the air because the water is heavier than air. But if the water is up there and I suck and put like this, the water will come inside. Okay?
If we do
So this is a very good question. This is suppose you are at night shift. Thank you, bro. They laugh now. Suppose you are at night shift and there is no underwater seal system, and this chest tube is broke. What will do? And you cannot clamp. Why? Because there is a lot of air leak. Just disconnect the tube, this tube, disconnect it, and put the tube in sunlight or water. Okay, it will work. It will work as a one-way valve for very urgent situation. Okay, it will work. The air will come out and cannot come in because there is water. So this is very easy principle. Now I want to stimulate breathing. Suppose this is my diaphragm. Okay, this is my diaphragm. Here, I'm breathing now. See, this is tidalization or oscillation. This is a normal oscillation. Normal oscillation is 10 cc up and down. Can you examine the oscillation? Why it's connected on negative suction? Can you see the oscillation? Why I'm doing a negative suction here on this port? Can I examine oscillation? No, I can't. No, I can't. Because the negative suction, this new technology here, actually I don't know the mechanism to explain it, but it's only negative suction. It's only sucked from the chest, okay? So there's no tidalization. Whenever I put this or this, do this or this, while something sucked always, I cannot see the oscillation movement, okay? So, while it's on suction, nobody tell me it's not working. Okay? It's working. It will work with air leak. You can see the air leak. Yeah, I know. If there is an air leak, injured lung, like we said before, and the air continues come from the lung, and there is suction, you will see air leak where? Here. I want to ask you a question. Is the bubbles that we see in the negative chamber or suction chamber, is it air leak? The bubbles? No. No, it's not air leak. What is the air leak? This is the air leak. You see the air leak now? It's here in underwater sea. This is an air leak. But this bubbles is not an air leak. The air leak is only here. Okay? Again, do I have to, when I say minus 20 negative suction, is it from the wall suction? No. No, it's only here. Okay. What is the right negative suction that I can apply? I cannot apply here now because we don't have negative suction. Is it bubbling like this or just to see a bubble? Just to see a bubble, okay? It's not right to just to do it because it will suck all the air, all the water into the suction, okay? After a day of suction, you will find all this water into your suction, into your wall suction.
So how much they will keep the pressure on the
All the wall suction, you know, it's not accurate, right? It's different. Every single room have a different wall suction.
Yeah.
So it's actually by my eyes, I can adjust this. Here. Apply negative suction in your wall and adjust it from here. Okay? Just adjust it from here, just to see a bubble come. A little bubbles, that's mean khalas. It's working.
Dr. Attia, we do have two patients having pneumothorax, and we are going to apply negative suction for both patients. Okay, for one patient. Which one we are going to choose? He deserves to have negative suction and
When to apply negative suction? Actually, this question, if you ask a doctor, some physicians, maybe they cannot answer. Okay? Negative suction have some advantages and some disadvantages. Some of the advantages, imagine that the lung is wounded a 5 centimeter, okay? And imagine that this capacity to drain 5 liters per se, 5 liters per minute, okay? And the amount of air is going from the lung is 7 liters. And this capacity only 5 liters, okay? So how can the 2 liters, the rest of 2 liters will stay in the chest, right? And the lung will be collapsed. So we apply a negative suction. The negative suction have this advantage. So the negative suction will help us to increase this capability to 10. This is as examples, not an accurate numbers. But imagine this also. If I have 1 centimeter wound in the lung and it leak about 3 to 4 liters per minute, and this can drain 12. If I am applying a negative suction on a wound, what will happen? I will suck more air from the lung, more air from the lung. So I will injure the lung more and more. So it's have advantages and disadvantages. Don't bother yourself by the indication of negative suction or not. Most of fluid need negative suction. But the air, it depends. It depends on the lung condition, it depends on the ventilator settings, it depends on a lot of things. Okay? But most of fluid, keep it in mind, most of fluid, pneumothorax or cardiothorax need negative suction, okay, to help the tube, not only by gravity.
So one patient we have bed and another limb patient. This is bilateral chest shear. So for this one, if we close suction, as you said, if there is no oscillation, no.
It's not working.
No.
You are right. This is a very good question. In a chronic patient, guy, in a chronic patient, imagine this cavity, okay? I put a chest tube to drain some pus or a fluid. Imagine this cavity. The visceral pleura is here, lung is here. Visceral pleura is here and parietal pleura is here. What happened with the pus or the blood, prolonged one? It will fibrose, okay? So this is a steady cavity. All what we are talking about the diaphragm is going up and the chest is expanded, it's not there. It's only cavity, the dead cavity. Okay? So the tube is there, draining well, it's draining 150 per day, but it's not working. You are right, it's not working. It's not working as oscillation only, because there is fibrosis all around the tube. Okay? But it's working as a drain. Okay? This is a very good question. After a while of the patient, you all notice this. After a while of insertion, after 2 weeks or 3 weeks, there is no oscillation movement. And there is drainage. Right? 24-hour drainage, you can find 200 or 300. But there is no oscillation. Why? There is fibrosis. All the mechanisms that we talk about, the diaphragm, and chest wall expanded, the diaphragm going up, it's isolated cavity. Fibrosis around the drain. Any question, guys?
Summarize it.
We should change the tube or we just...
No, we just keep it for drainage. Keep it as a drain. Not as... I don't care now about the negative suction. Okay?
Can you summarize just?
Yeah, we will summarize.
2 minutes.
So if I find some clots or something like an issue like this, can I will keep it?
Very good question, you remind me.
These according
Now,
to the policies,
yeah.
we are not allowed milking.
Okay, but you have to. This is the most important thing. You are not allowed for milking. I don't know why and who put this policy, but If I'm yeah, at 12 at night or at 2 p.m., 2 a.m., I found the patient, I look at the chest tube, it's not working, and I found a big clot here. So I'm not allowed to do this? Hello. Okay, don't do this. Don't do this. There is two ways of melting. Okay? Let's be a friend. There's two ways of melting. To get an artery or a clamp and do this melting. Okay? And there is another way of melting, this way. Okay? This way is easy. It's by your hand, not by an artery. Okay? So it will not crush. By the way, the right way to clamp. The right way to clamp the chest tube by
the clamp that we have.
clamp or artery? No, it's wrong. This tube actually is fragile. Okay, you can see it. It's good, but it's fragile to the metal. So if I clamp it by a clamp like this, it may be micro-injured and there is air will come inside. So what will happen? Put a gauze. Okay, and this clamp. Suppose this clamp. Don't put the clamp like this. No, put the clamp by the back of the clamp and close it on the gauze. This is the right way to clamp. Okay. Again,
If there is no drainage, there is no oscillation, nothing.
nothing. Call the doctor to remove the tube.
Yes. Actually, the first is from the side. What they will do.
Sometimes, you are right. This is all very good question. You are right. Sometimes, when the patient on ventilator, okay, there is a policy in medicine. There is if the patient on ventilator and the tube is not working, and it's not draining, and I keep the underwater seal. Why? 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 And the patient on ventilator.
Maybe to give negative pressure.
Prophylaxis. Because I put chest tube now in a critical patient. His coagulation profile is very bad. So the chance of recurrent pneumothorax or recurrent barotrauma is very high, critically high, 70%. So I just leave it there. It's not working, I know. It's not draining, I know. But I just leave it there as a prophylactic tube. Disadvantage of this? Maybe source of infection. Okay? So after 72 hours, it's absolute source of infection. We can lift it up to 10 to 15 days. I know, but this is not ideal. But as a prophylaxis, this is a good question. So,
does it worth it?
Yeah, it worth a lot. It worth a lot. Why? I will tell you. It worth a lot. Why? Because we are in good ICU. Okay, we have good staff. Inshallah, you are a lot. All of you have one patient only. You pay attention well for your patient. But in some ICU, one nurse is responsible for 5 or 10 or 6, I don't know how many, but a lot. And the doctor is not available. So the patient may collapse and nobody know about him. So if the patient have one attack of barotrauma pneumothorax, the chance of recurrent pneumothorax is 70%. It's high. Yeah, I know, we are here, we're paying attention 24 hours for the patient and monitored and everything. And if anything happens, you guys annoying, I know. But in some places, no, we leave it as a prophylaxis. Even here, because this is invasive, there is a lot of complication of insertion of this tube. I saw many patients died from insertion of chest tube. Died. Okay? Chest tube can go into the lung, chest tube can go into the heart, chest tube can injure the lung, chest tube. Chest tube is a very risky procedure by non-expert hand.
2 minutes remaining. I have one question.
Go.
If this water is finished,
This one is sucked in. If you stuck to our instruction or to what we say here, just to see a bubble, it will not finish. It will finish when you see a bubble like this. Okay, you can put another one.
My question is not complete. My question is
Good.
If there is water, if it's finished and staff long time they did not notice or something happened, they are busy with the patient. So what can be happen if water is finished?
There is no negative. Yeah, there is no negative.
There will be be any side effect or no?
It will affect as a prolonged time. Maybe it will affect the mechanism of the chest tube. Okay? But are we talking about underwaters here or the suction port? Suction port? Suction port, yeah, it will. It will affect. Because you keep it suction. If there is no suction. And this is empty, no problem. But if there is suction and this is empty, it will suck air into the patient. Okay?
What's the actual time like to clamp this one? Because sometimes it takes more time initially the patient, for example, to go up. So it will affect the patient.
Depend on the case. I told you. You can judge, by the way. From now on, you can judge. How to judge? If I see a lot of air leak coming from underwater, so mentally I'm thinking, if I clamp this, all this air will collect again into the chest. Okay? There is a lot of air leak with all aspiration and expiration. A lot of air leak. So if I clamp this, what will happen? This air will leak from here, it will collect inside the chest. So just pay attention if I want to clamp this patient. But if this tube is normal isolation, and I put it for only pleural effusion or hemothorax, I can clamp it even for 6 hours. Because there is no air, no air to collect, nothing serious. It just will collect some fluid. Guys, again, you are not allowed. You are not allowed. You are not allowed. You are not allowed to keep the chest tube on the ground like this. It's always like this. Okay? Why? If this chest tube is split like this, what will happen?
Water is down.
Water is down and the air will go inside. So this is serious. Okay, the best way to put a chest tube, this, or you are in ICU, hang it. You know how to hang it to the bed.
And
One.
if it's still ready, if you want to change.
Two, you are not allowed to put a line. I know you put pillows below the arms of the patient during this. You are not allowed to put this below the pillow. It's always above, just to see it. Yeah, because maybe you are very tired to check the patient and wear this yellow bloody things with you. And just leave it in front of your eye. Okay? You are not allowed to pass above the patient. You are not allowed to split. What else?
Bus.
You are allowed to melt, by the way. Don't think. If I'm putting a water here and it exceeds the yellow marks or the blue marks, what will do?
You will aspirate with the syringe.
No.
From where? From where?
To through this? No, not to through. This is
Like,
very expensive.
behind there is a small cover.
There is two valves here.
There you can aspirate.
By a syringe. Only by syringe. You put your syringe, this for underwater scene, and this one for negative charge. Okay?
In the water stream, what we put if the water level below 2 or above 2 centimeters?
This one, underwater scene, it's above or below. That's a very good question. This is designed by gravity. 2 centimeters of H2O. It's 2 centimeters of H2O. Meter and a half between, below the patient. The air will come easily, like this, like what I'm doing. Okay, and the air will not come hardly into the patient. But if we play with this, okay, either more or less. If I'm putting more water here till here, I cannot blow, by the way. I can't blow. So I will feel resistance. So instead to drain 10 liters per minute, I will drain 1 liter per minute. Okay?
Is there any condition in which we cannot clamp the
Later.
We cannot clamp the
I said it now.
No.
Yeah.
We can
If the patient is like this, guys. Can you clamp this? Can you imagine you can clamp this? All this air coming outside the patient, if I clamp it, it will collect again into the chest. So, nobody allowed to clamp this situation. Okay? Nobody allowed to clamp in this situation. Thank you.